Health Committee meeting to order at, I have 12:34. Shall we stand for the invocation? Father, thank you for today. Thank you for the provision just to get us here safely. We pray that our minds and hearts will be attentive here as we attend to our people's business in the health field. We know that this is vital for our people, and we see how you've blessed us with the new outpatient clinic, with the clinics elsewhere around our reservation. Your presence can certainly be felt and seen. Pray you be with our time together today. In Jesus' name, amen. Roll call, Shelley.
Yes, sir. Mike Dobbins.
Here.
Dora Petzkowski.
Here.
Keith Austin.
Here.
Danny Callison.
Here.
Julia Coates. Sean Crittenden.
Here.
Joe Deere.
Aye.
Rex Jordan.
Here.
Johnny Kidwell.
Here.
Daryl Legg.
Here.
Wes Snowfire.
Aye.
Joshua Sam.
Here.
Mike Shambaugh.
Here.
Melvina Shotpouch. E.O. Smith.
Here.
Kendessa Teehee. Victoria Vasquez. We have a quorum.
Thank you, Shelley. I assume you've had time to review the minutes. I would entertain a motion to approve the minutes. A second? All those in favor? Any opposed? Motion passes. Down to reports. Claremore Service Unit, Mr. George Vallier. George. Thank you for coming, George. Hello.
Here. Here, maybe you can understand a little bit better. Oh, you have my report there in your packet. One of the things I wanted to tell you about is the last 7-day positivity rate at Claremore is 29.2%. That's down a few percent from the previous weeks. We were right above 30% for several weeks there. Last week, we tested 332 with 97 positives. There was a question last month about our weekly budget, weekly spending allowance for PRC. The weekly allowance is $117,349. And that's just the appropriations, our line item divided by 52.
Yeah, okay. Okay. I'll have him.
We continue to do testing out front in the drive-through. We continue to have the vaccine room open 5 days a week, and the infusion room is still open 5 days a week. Going strong. Any questions?
Questions for George? Dora?
Good afternoon, Mr. Vallier. I just wanted to point out that I had done a review of the reports that you have presented to this body over the past year, and specifically from January of 2021 to December of 2021. And I show that there were 5,057 funded cases, of which 1,970 were Cherokee Nation citizens. So that's roughly 39%. At the beginning of this year, January, the format of your report changed a little bit, and it did not then include the monthly collected amount. So when I look back to, say, December of last year, and the collections there that month were $4,294,022. The total amount that showed for funded denials deferred is roughly $750,000. So I'm curious, on the amount collected, what all is paid for out of that amount?
The amount collected is the amount collected for the entire facility for all clinics. Everything comes out of that, salaries, benefits, utilities, anything that we need to operate comes out of that.
Okay, so that amount is not specific to the Claremore facility, but to, is it the IHS facilities in the state of Oklahoma, or,
No, those collections are specific to us,
okay,
but that's what we use it for at Claremore.
okay. And then, can you give me a explanation about the deferred cases? How is it concluded that they are deferred, and what is the process that a deferred case takes?
A deferred case is one that is not funded. That's determined by the Physician Review Committee. All the cases go before the physicians on Tuesday. They are ranked according to acuity, and then the PRC office starts paying with the most acute and pays until they run out of money.
And so if there's money left after paying the acute cases, are the deferred cases looked at that point, or are they looked at again at all?
No, ma'am, there's no money left. We pay until we're out for that week.
And so the next week, those deferred cases from the previous week are not considered?
No, because we have a whole new batch coming through for that week.
Okay. And in regards to your software, your reporting software, say your clinical software, what, is that an IHS program? Is that a commercial program? What do you use to input your clinical information into?
We use the RPMS system, the same system that Cherokee Nation had used before they went over to the private system.
Okay. So what I would like to ask is, I would like to get a list of just the Cherokee cases, and I want to be very specific about the time frames of those, so I don't have that in my mind at this second, but I
Okay.
will by the end of this meeting.
Okay.
I want a list of the diagnosis or plan of treatment for the funded Cherokee citizens. And I'm going to ask for a month at a time and maybe 3 to 4 months out of last year.
I'm not sure I can give a diagnosis. That's getting into HIPAA. That's a violation of HIPAA.
So how would you be able to rate the acuity of somebody that you could give us that information?
I don't know that I can give you that information.
I'm not asking for names.
Well, okay. Again, I don't know that I can, if you want to get together and we can, let's sit down and figure out what it is you're asking, you want. There may be another way that we can get information to you.
I want to know the severity of the cases that are funded of Cherokee Nation citizens. You know, if it's heart, if it's, you know, a broken leg or what, for just the funded cases.
Okay, I get what you're asking. Let me see what I can figure out.
Okay? And I think that's all I have now. Thank you, Chair. Thank you, Mr. Valier.
Oh, you're welcome.
Other questions for George? Wes?
And George, hope you're doing well today. On those deferred cases, can one appeal the deferred case to bring it back up before the board?
Yes.
Okay. I think when you were here last month, you gave the approval rating of Cherokee citizens that were seen, something like a 92% referral approval on specifically Cherokee Nation citizens. That leaves about a 6 to 8% denied, which I think that's the percentage that Counselor Petzkowski was looking at on those questions. Probably she's looking for more of a generalization of how severity those ones were being denied, but can't speak to that on her specific questions. But that's all I wanted to know, was if one could appeal the deferred accounts there whenever they came for that, and if they're able to go back before that border or that committee there, and you said yes. So, and then also the 92% approval rating for Cherokee Nation citizens. I think that's what you had said last month, correct?
That's what it was.
Yeah.
Last month.
Yeah. Okay. Yeah, I know they changed variation, but we were on that same track.
Little different numbers this.
Okay. Awesome. Just wanted some clarification on that.
Okay.
Appreciate you very much.
Keith?
I just want to clarify, was that a denial, was that percent related to just the Cherokee citizens or your population at large?
Which,
The number that the Councilor Nofire was referring to, the 92%?
he was referring to the Cherokee Nation approval rating last month.
Okay. So that was specific to the Cherokee?
Yes.
Okay.
That was in the report. I break it out by Cherokee Nation approvals, denials, and deferreds. Yes.
Okay. That's all.
Yes, sir.
Thanks.
Anyone else? Okay, well, George and I talked briefly about this before the meeting. We addressed, you might say, the productivity in the dental clinic, and if you look at it and calculate per day, really for the last 6 months, they've been seeing roughly about 19 patients a day, and they've got 6 doctors and 2 hygienists. They're in the clinic, so that means their professionals are seeing maybe 2 patients a day. And some of those doctors are making north of $200,000, and that's 2 patients a day. And a lot of it's attributed to the shortage of dental assistants. In fact, your report says on page 4 that you only have 5 dental assistants, but to have full staffing be 13 dental assistants. And kind of briefly tell the council the struggle or the challenge to find dental assistants there at Claremore.
Those positions have been advertised a couple of times, and the last time that they were advertised, we actually offered a hiring incentive. We still got 0 applications. We're getting ready to go out for another round of advertisements for those, and we have raised the hiring incentive just a bit. See if that helps.
Do you have to be native to work in an IHS clinic?
No, those are the first applications they'll send to us, and once we go through the Indian preference candidates, then they will, and we still have vacancies, then they will forward any non-Indian preference candidates.
Okay, so that's not a prerequisite to
No.
work for IHS?
No.
Okay. I know that dental assistants don't qualify necessarily for your pension, but for even new hires for doctors, do new hires still avail themselves of a defined benefit package? Do they get guaranteed retirement, new
Yep.
hires?
Yes, sir.
Now is that IHS wide? I'm
Yes.
just curious because VA has changed their new hires. They're going to more of a, similar to what we have, Cherokee Nation, they have a 401k for new hires in VA, and BIA as well. But IHS continues, any new hires, they still get that pension.
Yes, sir, as far as I know.
Okay. That should be a recruiting tool for you at least, yeah. Okay. Any other questions for George? Thank you, George.
Thank you.
You might stay around in case any of us need to.
Okay.
Specific, thank you. Before we move on to Dr. Jones.
Mr. Chairman, can I say something? I'm not sure that the council is aware, really too much aware of it, but I sat on the advisory council for the 17 Tribes Advisory Council for the IHS in Claremore. We meet about once every 3 months typically. And if there's ever questions that this body would like to have in that conversation, forward them to me so that we can make sure that those things that are of concern to us are being shared with that body as well. As typically the council person who the IHS sets in is on that advisory board, and so I welcome that at any time. Certainly, any question that you have that you feel like needs to be shared, send it to me, and we'll make sure that gets heard through the proper process there.
Thank you, Council Austin. Any other question before we get to Dr. Jones? You have a resolution in front of you recently here just today, and Chief Hoskin is going to just perhaps make some comments before we go forward here, before we get to Dr. Jones' report.
Well, thank you, Mr. Chairman, and councilors and Mr. Chairman, this resolution is not for consideration as an agenda item today or to amend the agenda, but I did want to give some thought to issues that have been raised by the council, put those thoughts down on paper to perhaps consider at next month's meeting. But given the level of interest and concern about services out of Claremore, I just wanted to take a moment to address this a bit. There's two things, Mr. Chairman, that I know for sure about our health system. One is that it's improving year after year, and that's not a statement on the past few years. It's really decades of progress. We've seen it. We've seen the correlation between Cherokee Nation exercising more direct control over our health care, and I think improvements on the delivery of that health care. And I think over time, as we've seen that grown, we see improvements, and I think we'll continue to see that. It's something about Cherokees taking control of their health care destiny, which we've been on a path for a long time to do. That's one thing I know. The second thing I know is that the Indian Health Service is our indispensable partner in doing that. And those things aren't mutually exclusive. A good relationship with IHS is really indispensable. And that's true at the Claremore Indian Hospital, and the services they provide are so vital. All of us, though, involved in this kind of work, whether they're elected officials or whether we're involved in administering health care, as George is, as Dr. Jones is, we always want to find opportunities to improve. And I think that there are opportunities to improve, because what we really care about is whether the Cherokee people and other Native Americans who are beneficiaries are getting the best health care, irrespective of who delivers that. But we also always have to have an eye out for opportunities for the Cherokee Nation to help IHS improve, because we have a level of expertise that I think IHS can benefit from. I think other tribes at times can benefit from. And we also would be wise to make sure we leave everything on the table when we think about how health care is delivered. And that includes the Cherokee Nation, again, increasingly exercising direct control over our health care for Cherokee people. I mean, look at the improvements that we've seen at Hastings, the difference between Cherokee Nation directly administering services out of that facility compared to IHS. And that's not to diminish the work of the men and women who work in IHS. Some of the most dedicated health professionals and administrators around work for the Indian Health Service. They work in a system that, in my opinion, is not a system as good as ours. And just be plain about it. I think our system is better. But we always want to do things to make each other better. And so I had reached out to Speaker Shambaugh and with this suggestion, and you all have just, of course, gotten this, probably haven't had a chance to review it. But what I would like to undertake on our part of the government is a review of Claremore Indian Hospital and those services that are delivered out of that facility, and look for opportunities to improve. And I mean, look at it objectively, look at it with the expertise that we have over in our health system, and do that over the course of the next year. And by the end of this fiscal year, have a set of recommendations, have a set of opportunities that we might look at and act upon. And again, nothing should be off the table in terms of improving health care for our people. I sat on this council, and I know what it means to have constituents call and ask questions about contract health, now called purchase and referred care, and to struggle sometimes to have an answer to those questions. Contract health's difficult, whether it's Cherokee Nation delivering it or directly by the Indian Health Service, because it's a difficult system to work in, and it's a system that we have to try our best to meet the expectations of the Cherokee people, and they ought to be sky-high expectations, but it's a lot of work and a lot of resources to meet it. So my suggestion, again, is not, Mr. Chairman, something that I would be asking the council to act on today, just something to think about between now and the next meeting, and it's something that, if there's sufficient sponsors, it may be something to consider next month. Again, it would put us on a path, both as an executive branch and a legislative branch, to commit to studying Claremore, what opportunities we can find to improve it, and nothing is off the table. We've got a lot going on right now in healthcare, a lot going on in terms of new construction, the hospital, the replacement of the Salina Health Center. We're working on some plans for behavioral health, drug treatment. But we've got to make sure we keep our eye on everything when it comes to healthcare. And I think that studying opportunities to improve Claremore is something that I know this council's interested in. And so I just want to get behind those interests with some substance that we can hold out to the public and say, yes, we are working on it, but commit to working on it and come here within a year and have some real concrete things on which we can act. So wanted to share that because I know this is of great interest. I also want to express my appreciation to our health leadership, which held some meetings for council members to learn more about Claremore IHS, because look, I've been at this a while, and I could use a tune-up from time to time on how IHS operates out of Claremore. In fact, if there's any more of those meetings, Dr. Jones, I may join any counselors who couldn't join the first round of meetings. I know many of you were able to join, but I think the door's always open, I'm sure, Dr. Jones, for any meetings for council members who could not attend. And like I say, I might join those meetings because it's a topic that's complex, but it deserves our attention. Mr. Chairman, I just wanted to share those thoughts with you. Thank you for the time.
Thank you, Chief Hoskin. Keith?
Chief, I would ask that a reporting schedule be added to this before it's actually heard, with like a 90-day report back to us and maybe a 180-day, so that it shows that there's a expectation of when we will hear back from you.
Certainly. I'll take that back and do some editing on this and send it back to you.
Thank you.
Any other questions? Okay, Dr. Jones, ready for Dr. Jones' report from Cherokee Nation Health Services.
All right, good afternoon. Thanks for having us. First, we'll just go through the report as we do usually, and I think you guys have it all in your packet. And just keep in mind that I always want to remind, this is from June. We're always in the rears on these reports, so when you read through it, keep in mind those are our June numbers that you're seeing. One of the things I want to highlight is, I know we're talking about contract health or purchase referred care, and if you see on there that we have 95% approval rate, and I did get the numbers, so for the month of June, we did 11,114 referrals, and 95% of those go right on through, and some of them, get caught up either for more information or maybe it's inappropriate. So just to give you an idea of the volume that our staff is constantly doing every month, and that's actually a low volume in the summer. Typically, we're around 14,000 per month, so just to give you an idea of that. If you look through, most of the numbers are continuing to be on the rise, so I'll let you guys ask questions if you have any questions on that. Just give you an update on construction projects. All of our construction projects at our clinics are on pace. We'll have those completed before the end of the year, so there's no delays holding us up in any of those expansions. Everything looks like it's moving along just like we want it to. As far as the hospital goes, we are in the third stage of development and planning and design, development and design. We're looking forward to seeing those final drawings coming out very soon. Our general construction manager's on board, and he is working with us to keep our budgets, to look at our budgets along with the design, to make sure that if there's any places that we need to look a little closer at or make sure we come in on budget. So we're already working on that. A couple of things that I wanted to highlight that we're working on. I know we're talking about purchase preferred care and what we can do to improve that, but I thought it was important to, give you a highlight on some of the things that we're doing. We've been working for almost a year now on a pharmacy improvement project. We had a consultant come in, and they're embedded in our pharmacy, looking at what ways we can improve customer service, inventory management, the way that we just interact with timeframes on how quickly things are being filled, and also looking at how we can utilize our refill center to the fullest capacity, because we're not using it to the fullest capacity at this time. We're doing a lot of refills out of our clinics, which takes time away from the patients that are standing there. So we need to reshape that a little bit, and they're helping us to do that. We're also just now getting ready to start a new project on phone service. I get a lot of information back sometimes from you guys and sometimes from patients directly where we're not answering our phones the way we should. So we're going to be doing some secret shopper and stuff and finding out for ourselves just how many phone calls a day aren't getting answered, aren't getting returned, and we're going to start working on that. So hopefully you'll see an improvement in that in the next few months, and see if our customer service can't tick it up a little bit. So just wanted to let you know that stuff's going on. We're also, as Chief mentioned, looking at all the ways we can expand our behavioral health program. We're being asked to do that in various ways, and so it's a little bit of an issue with staffing and availability of staffing in our area, and we're looking at ways to recruit those individuals in. So we do have it on the radar, and we are working on it. It's just a little bit difficult right now to find those individuals out there to fill some of those vacancies that we had, but we're working on it. We've got our recruitment department looking at that full steam right now. So with that, I'll end my remarks and answer any questions.
Daryl?
Dr. Jones, is there any plan for the new hospital to have like an inpatient rehab for those that have just come out of surgery? Some of the calls that I've received and issues, I think I've talked to you about them, is they get like 2 weeks out of rehab center, but then the doctor's saying, hey, you probably need to be here 3 or 4 more weeks, and there's nowhere to send them, and Contract Health can only do 2 weeks of it. But are we planning on constructing any type of, physical rehab center for folks that are getting out of surgery that just needs more time? I would just like to throw that out there. I think that'd be probably a good idea. I don't know if that would be a cost issue or if we're able to third-party bill on anything like that, but.
It is something that's been discussed. It's been brought to the table. We have brought our staff in and discussed it with them. We're really looking at what weighs out better. Is it better for us to own it, or is it better for us to contract with it?
Right.
Are those people available? Is that something that is feasible for us to do in-house? So it is on the table. We have it on our radar, but we haven't made a decision yet.
Thank you so much.
Okay.
Yeah, Doctor, thanks for visiting with me a little bit up front. One thing in your behavioral health conversations you probably already do, I don't get many of these calls, but I had one this weekend about a gambling problem. I believe it was her husband that she didn't tell me, but said there's a 2-month wait to speak to somebody, a therapist or something, and Mr. Caldwell, he said, that's about right, because that kind of training, not a lot of people have it.
Right.
So, like I said, it's not something that's blowing my phone up, but to this particular family, in our behavioral health discussions, it might be a good thing. I worked in the gaming industry for a while, and, there's people that come in there and drop $20, $100, but there's people that really, really get depressed after a big loss. And so if you'll add that to some conversations, future conversations, I think it'll do some good in the future.
Yeah, we do have, as you know, we do have some waiting lists at some of our facilities more than others. And when someone does call, there's an intake that's taken, and a behavioral health person does an assessment and then assigns an acuity level to that. So obviously, someone who has a homicidal, suicidal tendency, they go to the front of the line versus someone who has a little bit less of an acuity issue. So, but I do know that there are people in our system that can address those type of things. So I'll, if you'll get with me maybe, and we'll look at that case and see what we can do.
Thank you. And as you know, in your profession, there may be a fine line between this problem and
Right.
suicide.
Absolutely.
Thank you.
Yeah.
Dr. Jones, I'm glad to hear that you're working on the phone. Seems like that's the biggest complaint that I get, people not getting return call or not being able to get through. Seems like that's a daily thing that I get, so glad to hear that you're working on it. Thank you.
Yeah, it's something that we experience internally also. So I think some of the confusion came from having to have a new area code and the new phone system for CNOC that's different than the 918 area code, and it causes a lot of confusion. And when people see a return call that has a 539 area code, they don't want to answer it because they think it might be someone calling from wanting to sell them something. So so we do have some of that where we document, we try to return a call and we don't get an answer on the other side of it because people don't see, and that may be part of our problem. It's not identifying through the caller ID that it is Cherokee Nation calling. So I know we're working on that too.
Yeah, Dr. Jones, I've received several phone calls also, like Councilman Crittenton, and the people tell me that they're told there's a 6-month wait at J, at Sam Hyder. It's a long time. So I'm hoping that when we build this new clinic, that, if we just have one at J, and I know, when you try to plan for the future, it's difficult to maybe see how things are going to be in 5 years or 10 years, and sometimes it's hard to prepare for that. And I know that we are down on some employees, and it's hard to fill those roles, but I know that whenever we build this new behavioral health center, I know that's going to help a lot when it's just specifically made for that. But in the meantime, I hope when you build a Salina clinic that you all take that into consideration, that, one's probably not enough. If it can be staffed with more, I mean, you got to be seeing these things, and it's becoming a bigger and bigger issue. So just an observation, and just wanted to let you know that I've been getting the same complaints. Also, it seems like the people left without being seen's up a bit. Is there anything any attributes to that, why that is?
I don't have anything to tell you exactly why that is. Sometimes it has to do with wait times. It has to do with people coming in to be maybe a lower acuity and having to wait a little while, and versus someone who's coming in with a higher acuity. So because all those patients are triaged too, that's how we track that. From the time they step in the door and they sign in, then we start tracking that time. So those are typically the issues. Maybe we had more patients coming in with a higher acuity, and we had some patients that were there maybe just to get tested, for something, or just to follow, coming in with something that's they didn't want to wait for. So I don't have an answer for you for that, but typically that's the issue. And to go back to your behavioral health issue, we are doing a reorganization of behavioral health. Julie's working with us on that to make sure that we are trying to increase the amount of staff that we have at the different clinics, and also look at productivity at the clinics. Are we utilizing those folks to the maximum of their licensure? So we do have some things in the works that the next fiscal year will allow us to open up some more positions that we put into the budget. So we are addressing it, and we do know that there are waiting lists out there. It's different at different clinics. Some clinics, it's not as long as others. But typically in the rural, very rural areas, it's a little bit harder to find those individuals.
Okay. All right, well, I just thought it was odd that, in May it kind of bottomed out and then it just shot up real high of the people who, weren't seen. But, and I know there's various reasons for that, but I just didn't know if you had insight on that. All right, thanks, sir.
It may correlate too with the rise in COVID cases.
COVID, yeah, that's what I was kind of wondering. I just didn't.
I'd have to look,
bring that
do an
up.
overlay to see, but I would imagine it's going to correlate somewhere in there.
Okay, thanks, sir.
Yeah.
Dr. Jones, have we thought anything about, I know being a dental hygienist or a dental tech, TCC, and I think OU just opened up maybe a branch in Tulsa at the Schusterman Center, but have we thought anything about, along with our medical facility that we have here in Tahlequah, maybe training these folks, giving them an opportunity maybe that they can work with our clinics and throughout the nation?
So we do. And we do work directly with OU and with Joplin and with TCC. We do have agreements in place that those dental hygienists are able to come in and do rotations in our clinics and do clinicals. It's a different training than a dental assistant. A dental assistant is more of an on-the-job training where we can start somebody with very little knowledge in the field, and we can train them from the beginning. A dental hygienist is a licensed individual, so they do have to go, and most of the time they get a bachelor's degree and then go on. In some cases, it can be an associate's, after 2 years and go on to dental hygiene school. But we do have those agreements in place, and those folks do circulate through our system, and which gives us a great way to recruit. And typically, we don't have an issue with recruiting dental hygienists. We don't have an issue with recruiting dentists. We do have in some areas a little more difficulty with dental assistants, but it hasn't impacted our productivity. We're still, our providers are required to see 12 to 14 a day, so people a day. So it hasn't impacted our productivity at this point.
I appreciate it. Chair, 2 questions. I know as we're going under this study that we're going to possibly take a look up next month on the agenda, what percentage, can we get a percentage of patients that Cherokee Nation Health System sees that are Cherokee citizens versus non-Cherokee citizens? And then can we get a percentage of contract referrals that are approved that also have health insurance? So that we know the approval ratio differentiates between there, and the approval differentiates between what we're getting from Claremore Indian Hospital. That would kind of help us out a lot, I think. If you can get those numbers to us, would be great.
Okay, so you're asking for the percentage of Cherokees versus non-Cherokees?
Right on.
That are seen in our health systems or
That
contract?
that are referral approvals, yeah, in our health systems. And then the same goes for which ones have insurance and which ones don't. A percentage of insured referrals and non-insured referrals approvals.
That doesn't have an impact on our approval rate, whether they're insured or non-insured. That has no impact, so we don't track that. The only impact that has is on the end when we pay our bill.
Right.
If they have had insurance, then we're the payer of last resort, and it's up to the provider that we referred them to bill that service, Medicaid, Medicare, private insurance, whatever, and then give us the EOB showing what they paid, what's left on their balance, and then we pay it. So it's not something that goes into any kind of calculation or any kind of tracking. We don't track that per se to say, okay, you have insurance and you don't. It's if there's a referral need, it's referred, and that's done on the backhand side, on the back of the referral.
Yeah, I knew that might be a difficult one to track because, well, also patients have a privacy that whether they're insured or not. So I didn't know if that was something you'd be able to deliver us. No, I wasn't saying that was a question of whether or not we get the referral approved. I was just trying to say, overall, money-wise, how does that end up? Because we are able to bill those citizens that have insurance.
So the way that works is once we initiate a referral.
Right.
Let's say the referral is going to be $100.
Right.
Then we're going to put and encumber $100 in our account and say
Right.
that's $100 to pay for that referral. Now, on the back end, if that patient had something that paid $50 of it,
Right.
then we would only pay $50, and we'd have $50 put back in the pot to continue to help more people.
I know we have a breakdown. I have to look through my notes because I think we do have a breakdown of where what's the proper word? We reoccurred back the funding from the insurance company and be able to make our contract dollar stretch further. I'll look that up. I think we have that somewhere in our budget.
Now, that occurs, that recoupment occurs if someone has not disclosed to us that they had insurance or they had a
Right.
third party, and we paid the full amount, and then later we find out that the provider or someone got paid for the insurance or third party, and they got paid by us, then we recoup that money back.
Right, okay, perfect. And then, a last thing that Counselor Crittenden brought up, I was gonna bring this up, in next, meeting, but I figured this might be a good setting, especially because we have the chief here too. I was at the, he brought up that depression and suicide issues, trying to see someone, but it was also related around gambling addiction. I know that can be an issue, especially since we run casinos, and we see a lot more people in this area, say, another state that doesn't have casinos. We're gonna have some citizens that deal with that and possibly use that as an outlet to try to self-cope, self-medicate, and we need to help treat those citizens. But at the same time, I think we could take a look, and since the chief's here and he can hear that, as be the first of its kind to maybe start a self-regulating gaming on how we service citizens that are on low-income subsidies. They have to go through our human services, which is where I was gonna bring this up at, and also get with our gaming compliance of saying, well, if you're on a low-income subsidy, then we have to look at trying to self-regulate, help you self-regulate from gaming, so that way it also helps out on your issue that you might see with depression and suicide-related issues that might come up with that. So that's kind of maybe a collaborative effort, since you're in here in this room, just to kind of hear that. I think Chief's here to maybe talk about
I just-
possibly doing something like
Well, I
that.
just want to make sure I understand the question. So if a Cherokee citizen is on some form of assistance, perhaps they needed rental assistance or utility assistance, would they then be banned for some period of time for entering our casinos? Is that the proposition?
That was kind of what we talked about whenever we were at IGRA this year out in California, was they had a committee there, and they were talking about tribes learning to self-regulate to try to help that issue specifically on depression and suicide issues out. And I thought one way we could look at it would be to help self-regulate better would be the people that are struggling financially that come to us that need help with financial services. Maybe we're able to, that be a kind of a stopgap right there. I'm not saying everyone who is even remotely on services are addicted to gambling, but you know, if it's a struggle financially, you also don't want that as an outlet to also hinder your ability to get out of that struggle.
Certainly a broad and important topic. And Counselor and Mr. Chairman, I would say that particularly in our Human Services Department, when people come in, there's often an analysis of their budget and to help them sort of look at the money that they have. I had not heard a proposal along these lines, so I'd be interested in learning more about it. It does raise some questions about, a lot of questions, but certainly the mechanics of a proposal of this nature would be interesting to look at. Thank you, Mr. Chairman.
Appreciate it. That's why I was just bringing it up, thought we could start kind of that discussion there, and I'll send some more information of kind of what I've learned and how that might work, because I know Counselor brought it up there, so I just figured it'd be a great chance to kind of leeway into that discussion. But yeah, those are the two questions I had, and just kind of wanted to comment on what Counselor Crittenden had, so appreciate it.
Just to follow up, Doctor, first, thank God I don't have to deal with this much, but I was really impressed with my appointment message that I've gotten a couple, really to the point, and want to make sure you're coming to your appointment, and I'm sure that's system-wide, so that was really convenient and professionally done. Wanted to brag a little bit about that. Had a question on contract health, just I need to make sure I'm on the right track. At large, they can come and use our facilities, but the referrals out rarely, or kind of we don't refer at large, right?
Right.
And
through purchase referred care.
Now,
Yes,
here's
there
two
are,
dumb questions right here.
Yeah.
Podo, would that be considered contiguous?
I don't know that for sure. I don't think so.
Okay, I didn't either,
But
I-
keep in mind, there are some situations, kind of like our denture program,
Mm-hmm.
even though that's done through contract health, that we are able to refer some of those folks out and do a non-payment contract, which means that they get the same price that we've negotiated with our vendors as long as they use one of our vendors.
Okay.
So instead of paying the full price, they get a very, very discounted price, and they get the benefit, but we don't pay for it.
of course, not working with that large very much. I just learned something. That's a really, really good thing right there. That'll help me. Last thing, and I don't know, I've had a couple people bring this up, like Wilma Mankiller, 696-8800. And that's the number that pops up on phones if it's a dental or a vision or anything. And I don't know the feasibility of ever changing that, if we would want to change that. I don't know how much confusion it causes, but a couple cases, you know, they didn't know really who was calling. They should have a pretty good idea. Like me, I have a pretty good idea who's calling from that number. But just like I say, if we want to look at the feasibility of something like that, maybe each department that might require a receptionist at each department, that might not be the way to go. But I've had a couple questions about that.
So in your area in particular, we do have an issue with that third-party vendor that handles the phone lines and having the access lines into that clinic. We also have an issue at another clinic in Oshaleta, that's a similar deal. So even though we have one trunk that comes into the clinic, then it branches out to the different departments. But the different departments, when they call out, goes back through that one trunk out. So that's why you get that 8800 number coming up, and the operator doesn't always know where that number came from. So they should be identifying themselves, number one, where it comes from. Number two, we're working on moving toward having more text messages that go out rather than phone calls. So that's kind of the standard now, is text messages. I know when I go, if someone gives me a text, one, I'm going to make it. Two, I need to reschedule. And then they know to call me. So we're working on getting that same system going inside of our system. But it's a little different. People are used to getting something by mail, and typically, sometimes they don't get their mail until the day before the appointment, or maybe the day of, and we've seen that happen too, and so they miss their appointment because they didn't get their letter in time, you know. So there are some challenges there that text messaging will take care of.
Well, good. And just to kind of close out, you know, Bobby sold that little piece of property across from McDonald's, used to be your place. So he gave me the sign, you know, Bobby Crittenden DDS. And so I'm gonna hang that in my shop. Well, his name fell off, and there was your name.
There's
So
my name.
you got the sign made years ago, right?
Years ago,
So if you ever want a photo op, it's gonna be hanging in my shop. And so
I think,
take his name off. And however we want that
1996 maybe,
picture.
so many
But
years ago.
That's a heck of a sign. I mean, it's pretty
Lasted a
nice.
long time, didn't it?
Thank you, Doctor.
Dr. Jones, when we had our contract health with Steve Carey was excellent.
Good.
And I appreciate that, and, boy, it just wasn't long. We have questions and very good. One question that I don't think was answered, if you refer a patient out, okay, and let's say they went to a cancer treatment center, all right, does that bill come back to the nation, or does that bill go to that individual? Because that seems to be in my helping the last year with contract health. Sometimes they say they don't have the bill, and sometimes the patient gets the bill not knowing that the Cherokee Nation that referred them and is going to pay the bill actually knows what the bill is. Is that just misunderstanding, or is that something that we need to look at?
So typically, when someone's referred, they should get a referral page that goes with them. And that is the PO, so to speak, to tell that vendor that we have a contract with that Cherokee Nation is responsible for that bill, okay? Sometimes people go on their own, and when they go on their own, they don't have that paper with them, or they don't take it with them, then that provider is not going to sign Cherokee Nation as the responsible party. They're gonna sign up the person that shows up there as the responsible party. That's where the confusion comes in. And so when they do their billing, they're gonna send it to the responsible party. So there is a responsibility on the part of the patient that when they go for that appointment, if we haven't set it up for them, if we set it up for them, then they're gonna know that we're the responsible party. If they go and they have got a verbal referral and they go on their own and they don't go through the correct process and have that piece of paper with them, then that entity is not going to say Cherokee Nation's responsible for this bill because they can't. They have nothing proving that Cherokee Nation's responsible for that bill. Otherwise, you'd have everybody in the world go and say, oh, Cherokee Nation's paying my bill. So there is a process that takes place, and typically what we find when the bill goes back to the patient is the process wasn't followed.
So the patient, if they have a written referral, should never receive a bill at all?
Right. They should be giving that to, when they go to that entity, they should be giving them that, and it acts just like a PO. It acts like a check, or basically a assignment of responsibility for us to pay that bill.
So when they're said that they have to sign the agreement that says they're gonna pay for this, they shouldn't have to sign that if they're carrying that referral with them?
Depends, because you could go to a place and on that PO, it's gonna have a dollar amount. It's gonna say, this is what we're referring for, and this is the dollar amount we've assigned to it based on our contracts that we have with those vendors, okay? But if you go and that provider says, well, I think you should have XYZ done, and you're gonna go outside of that dollar amount, or it's something that we do internally that you could come back to us, say an MRI. That doc wants you to have an MRI, then you can come back to us and we will do the MRI. We're not gonna pay that doc to do an MRI on you in his office just because he has one. Does that make sense?
Yes, sir, thank you.
But now a patient may choose, oh, let's go ahead and do it today, I'll just pay for it. They can choose that, but we don't obligate ourselves to that.
Just real quick, going back to the behavioral health, you know, the old clinic, the old Sam Hyder Clinic, Grand Lake Mental Health moved into it. Do we have anything with them do we contract them or anything I thought that we did.
We do.
For them to see some of our patients?
Yeah.
Okay.
And we have that in various communities. The issues are the same for them
Same
as they
thing
are
for
for
them.
us. There's
Yeah.
waiting lists to get into those facilities, but we do have agreements in all of our, in most of our areas that with outside entities to help us offload some of the waiting list.
Okay, and just a observation, virtually in every casino I've ever been in, there's always a sign when you walk in. If you or like a loved one have a gambling habit, here's a number you can call. I thought that was kind of interesting just because I thought, how many people actually call this number? But it is offered to people in the casinos. I don't know how often it's used, but I know our casinos have them. So that may be something to look into later too. All right, thank you.
Yes, down in our area, like if Tahlequah calls, it'll say the number and then it'll say health center. But like if Three Rivers or Redbird calls, it just gives the number. I think if we could somehow implement that in where it would say health center, on there would be a lot more of those calls answered. It's not that big a deal, but it might help some.
Yeah, and this is not a new issue. We've been dealing with, you've got to deal with the vendors. You've got to deal with AT&T, with, the people who out there that own these lines, and they have to agree to do it, and that kind of falls into our IT department, and we've been working on trying to get that. In some areas, we've gotten it done. In some areas, it's terrible. It's really hard to get that caller ID assigned, and it's at their leisure. There's nothing requiring them to do it. So we can just continue to request and leverage our usage, and I think Mr. Gord has been doing that to try to get that fixed, but it's a little bit frustrating for us too.
Before I let you go, Dr. Jones, the lines for prescription drive-throughs at our clinics, primarily because of the heat, right? Everybody, any medications that are temperature sensitive, we have to go in and get them, whereas before we got them in the mail. Do you have a date that you're going to say, okay, we don't have to abide by that, or you're just going to play it by ear?
No, we have a third-party vendor that we're doing some test cases on now and putting in the mail and seeing, doing the due diligence to make sure that we can ship them safely. And so I've been out for a week, so I'm not sure where we're at on that, but the last time I checked, we were in the final stages of that. So that has caused a little congestion because of the heat that we've had this summer and causing us to have issues with, it's not only insulin, there's other medications too. So it requires people to come to the clinic to pick it up. And I know it's a little bit inconvenient, but it's safe, and that's what we're trying to do.
All right, thank you, Dr. Jones.
Thank you.
Cherokee Nation Public Health, Miss Lisa Pivek, and I saw Dr. Gann back there.
Yes, he is. He's in.
Wow, there he is.
There he is. I'll try to be quick. I know we're running up against the 2 o'clock hour and other meetings, but thank you for having me, and it's good, always good to see you. Good afternoon. I have a few things on the report that you have that I would like to highlight this month. July was an extremely busy month in the first part of August. I'm happy to let you know that all of our documents for public health accreditation are completed, and all of our documentation for everything has been submitted to the Public Health Accreditation Board. So we now just sit and wait for feedback and review of those documents for the next step. So that is a big move. That for us was a big relief. That took hours, hundreds of hours of work and hundreds of pages of documentation for a whole lot of staff. And we were really appreciative to have staff that could get to those tasks. I want to highlight a little bit under the cross-collaborative with Cherokee Nation Education. We're getting ready to move into phase 2 where we finalize the Cherokee Indicators of Wellness, talk about the priority indicators, how we include more staff from other divisions, and then how we put measurements on that. I am at the August TAC meeting, Tribal Advisory Committee, that was held here last week before last. I actually presented all of the work from this collaborative to the entire CDC board that was there, CDC guests, and got a lot of feedback on interest in assisting or following what we're doing. So that leads me into talking a little bit. The Tribal Advisory Committee meeting was held here in Tahlequah. That's the Tribal Advisory Committee for the Centers for Disease Control and Prevention and the Agency on Toxic Substances and Disease Registry, ATSDR. That was chaired by Deputy Chief Warner. The Tribal Advisory Committee, just so you have a little more understanding, there are representatives from all 12 Indian Health Service areas on that board, on that committee, as well as 5 at-large positions. So many of those were here and some of those were on virtual, but we had a really full meeting and held here on site at the Chota Center. Deputy Chief Brian Warner, who is the chair of the committee, chaired the entire meeting along with Dr. Jose Montera, who is the Director of State, Tribal, Local, and Territorial Support. And he was the lead CDC representative on site. So it was a smooth 2-day meeting. I hope that some of you got to see or hear some of it. I will briefly tell you just a little bit about it. We did get to address CDC Director Dr. Rochelle Walensky virtually, and we had a question and answer session with her. The leadership from these centers, the Center for Environmental Health, the Center for Emerging and Zoonotic Diseases, Healthy Tribes, Center for Surveillance, Epidemiology, and Laboratory Services, Associate Director for Health Policy, and the Division of Adolescent and School Health. All of those directors were on site for the meeting, and including a few more that I did not list. And the main topics discussed were environmental justice. CDC has new projects working around environmental justice. Technical assistance, we just learned so much about the technical assistance that's now available from CDC in every division, center, and office. And we have actually already reached out for technical assistance for our surveillance system and developing it further and modernization of it, so I'm looking forward to that. We advocated for funding availability expansion for tribes. There are a lot of opportunities that come open that are only open to states, and tribes are not included. So we continue to advocate to have that open to tribes as well. And we talked a lot about the social determinants of health, to include how CDC is addressing that specifically to tribes. Measurement of social determinants of health, specific issues that relate to tribes, and how they quantify our progress on social determinants of health. At the WIC program, we've seen an increase in what's called standard formula or milk soy-based formula on the shelves in the last 4 weeks. And we're still, however, having a little bit of trouble with a few specialty formulas. And the WIC staff are happy to get with each WIC participant and even non-WIC participants that call and help them locate, work correctly with the WIC participant and help locate where that formula might be and help them get access to it. I also want to thank the health services because WIC received several special formula shipments from our partnership with Cherokee Nation Health Services, the formula manufacturer and distribution warehouse that we usually get our WIC from, and they were able to get several shipments in. So we're seeing some improvement on that, and I'm happy to see that. The last thing that I'll mention quickly before I turn it over to Dr. Gann is that we were awarded another CDC grant. It's called Healthy Tribe, and the Healthy Tribes Division. It's called Tribal Practices and Wellness for Indian Country. It's a 5-year initiative, and we are working closely with education on the programs for that. And so we're happy to announce that as well. And with those words, I will take any quick questions, or I can turn it over to Dr. Gann for an update.
Questions for Lisa? Lisa, just on the Native Diabetes Prevention Program on page 5 of your.
Yes.
It lists the number of participants. Is that kind of what the number that we were looking at, or we, like for Muskogee, it just says 3 participants?
Yes, so the Special Diabetes Program for Indians functions and distributes that diabetes prevention program. They administer it, and all of our referrals come from the diabetes program, and that's not located within public health, but we take those referrals. The issue right now is really that there has to be certain clinical parameters that you meet to get in the diabetes prevention program. And so we're trying to expand in public health to a more community-based version of diabetes prevention program, the DPP, so that we can include anyone that wants to join as well as their family members. So that has inhibited participation, I would say. And hopefully on our new planning for the FY23, we're seeing us put an increase on that. Because I too have noticed that, those low numbers, and it's disappointing.
Yeah, it is. Does that mean the participants have to be pre-diabetic, or can they be insulin dependent?
They have to meet a select criteria. They're somewhat pre-diabetic. I think there's a more specific metabolic syndrome that they have to meet for that. So
Thank you.
I'm of the opinion that let's find a way to get everyone in so that they don't have to get to pre-diabetes before we start working with them.
Right.
Thanks.
Sean?
Counselor Sam, I think he kind of brought it up, like our wellness center coming to Stillwell. You know, a way to get them in, and he referenced the WINGS program, which there was some incentive, you know, and I think he mentioned do so many miles or laps, a water bottle, sweatshirt, and, you know, dealing with, you know, our area.
Yeah.
You know, we got to get them in there.
Yes, we do.
And awareness, just, I don't know, if you don't care to jot that down.
Yep.
Incentives, when the wellness center comes, you know, I'm not smart enough to come up with the criteria of the incentive package or whatever you'd call it, but, you know, I've said this about the language, and I wasn't the first to say it, and, you know, we're doing great, but let's don't ever forget the incentive thing, because most of the things, you know, that we adults do are for incentives, most, not all. But if you don't care to
Absolutely.
jot that down, just somebody smarter than me figure out how we could entice, you know, maybe a certain weight category, or maybe somebody with diabetes, hey, come here, you know, so many times, let us check your blood sugar, and, you get my
Yeah,
drift.
absolutely, and we are doing a full review of the WINGS program. Counselor Sam must have been in WINGS when he was this tall, because we used to have that, 100 miles, you got this,
He
you
eats
got
a lot of
all the way
wings.
up to all the way up to the maximum, you get a whole new jogging suit, you know, so. Your
Thank
shoes, you could get shoes, yeah, absolutely. So, we'll be looking at that, and I hear the incentives for, WINGS, I hear that talked about a lot, as well as participation in the other wellness activities. I think, that will give us an avenue to probably also recruit. We should implement thoughts along those lines with a lot of other
Thank you
programs that we're
for
doing.
the job you do for us.
Thank you so much. Dr. Gann, you want to come take?
Good afternoon. It's good to see you all again. As usual, talk a little bit about COVID and some of the other things you probably saw in the news over the last month. Nationally, the number of COVID cases has gone down a little bit. We're still over 100,000 per day on average, but tends to be trending down. It's really difficult to analyze those numbers because still, as I mentioned last month, a lot of people are either testing at home or not getting tested. So we don't really know the true number, but it's out there. We're still at around 400 deaths per day across the nation, and the benchmark we're looking at is when we get below 100 deaths per day, then that's more like the flu. So that's kind of what we're looking at. And we're still about 6,000 hospitalizations a day in the United States. We don't know if those people are in the hospital because they're sick from COVID or it's an incidental diagnosis. There's no data available for that. In Oklahoma, the numbers went down a little bit last week, but at Cherokee Nation Health Services, we had a dramatic drop in cases from in the 500s to the 300s, 140 cases over the week. Our average is just below 50 cases per day. We haven't seen that in a good 6-7 weeks, and our positive test rate is between 13 and 14%. And we're testing about 400 people per day. So that's all good news. We're concerned, of course, with schools coming back in session and how that will play out. But there's plenty. Some new data I found at CDC. They've tested people across the United States for the antibodies to COVID, the antibodies that show you've been infected. You get different antibodies when you are vaccinated. But the prevalence in the United States, their estimate for people who have been infected with COVID is 58%. And for Oklahoma, it's right at 70%. So that's quite a bit. Unfortunately, we know that the antibodies from previous versions of COVID, we're still dealing with the BA.5, don't provide a lot of protection from getting COVID again, but it's still protecting people like the vaccine from severe disease and death. So the CDC changed their guidelines. They updated the guidelines for the general public and for schools for isolation and quarantine, and we pushed those out and implemented them in our public health department and our advice to our patients. What hasn't changed yet is the isolation and quarantine guidelines for healthcare personnel. So that should happen this week, and I think it'll be dramatic. So as of today, we are no longer quarantining people who are close contacts of people who've tested positive for COVID. It's a huge impact on our schools, especially our early childhood units and Head Starts. And we'll see how it affects everyone else. So no more quarantining. Again, that excludes Cherokee Nation Health Services and other healthcare providers. When those come out, we'll push them out. The other thing in news, of course, is monkeypox. We've had 12 cases in Oklahoma and quite a few cases nationally. We're over 11,000 cases now for monkeypox. It's still primarily a disease spread by men who have sex with men, but it's starting to cross over into other groups, including children and pregnant women. Our providers have been extensively trained on recognizing monkeypox and what to do if they suspect it, how to test for it, and who to notify. We've tested 2 people in Cherokee Nation, and they've both been negative. We haven't had any cases among our patients. And those numbers on monkeypox come out once a week from CDC as well. Our syphilis cases have been going up a little bit. We had a pretty big jump over the last several years. The number of cases have doubled. This year, we're probably going to have more cases than the previous year, but probably around 150. And it has a tremendous impact on our pregnant patients, and we're pushing out, information to the public how to prevent syphilis, how to recognize syphilis. It's super easy to treat. It's either 1 shot of penicillin or 3 shots of penicillin, and it's easy to test for. It's a blood test. So we've upped our game on testing, especially with pregnant women, because the babies are vulnerable. A pregnant woman can pass it to her baby before it's born. And our pediatricians and our infectious disease department are pros at finding that and treating it. And then, unfortunately, there's a polio outbreak happening in New York State. When was the last time we talked about polio, right? It's been a while. There's a very large group of children who have not been vaccinated against polio, and CDC estimates there's somewhere between 100 and 200 cases. Most polio is not symptomatic, and I'm not old enough to remember what it was like before the polio vaccine, but I've got the scar from the vaccine. It doesn't cause a lot of disease, but when it does, it can be absolutely devastating. So we're keeping an eye on that, and every health department around the country is watching for that. Lisa mentioned the social determinants of health, and as the head of our epidemiology department, we're really excited about the collaborations we're building both locally with health departments and also with federal experts on surveillance. Right now, we do a lot of measuring of heart disease and cancer and people who smoke, but taking a step a little bit further back of the other social determinants of health, employment rates, education, violence against women, clean water, access to food, all those things that we're learning how to measure those for the Cherokee people to get a little bit on that front end of preventing chronic disease. We're never going to have enough contract health money. There's no way. We're also making those huge investments in improving the social determinants of health to try to prevent disease. So know that we're working on that and we're working hard. That's all I had, Mr. Chair.
Questions for Dr. Gann? I see none. Lisa, did you have a comment?
I thought about a comment I needed to clarify. So the diabetes prevention program, those are funded through Indian Health Service grants, the special diabetes program for Indians. And every grantee that does DPP has to follow that specific guidance from the Indian Health Service on those grants. So our look is to how do we keep that going, but also offer another alternative for persons who do not have metabolic syndrome.
Thank you, Lisa. Certainly thank everyone that came and gave a presentation. George, thank you today, and Dr. Gann, Lisa, and Dr. Jones, thank you all for coming today. Okay, I see no old business, no new business. I do have a couple of announcements. Dr. Callison, Danny mentioned reference to the OU College of Dentistry is opening a Tulsa branch at the Schusterman Center. They're actually open already, but they are going to have a ribbon cutting on August the 23rd at 10 o'clock at the Schusterman Center. That will be an opportunity if you have friends or family that live in the Tulsa area, especially if they're non-beneficiaries, they can go to the dental school and get, you might say, discounted dental work done there. So that could be a possible opportunity. And also next month from our medical school, we're going to have Dr. Natasha Bray, the interim dean, will come and give a presentation. Any other announcements? Okay.
Here in a minute, we'll have Education Committee, and Diane Kelly will be here. And, you know, there was a time that we used to put out, we used to train dental assistants. We saturated the market so much that we trained way more dental assistants than what we had jobs available. If we could do that again for the Claremore area, you know, with hopes of a job at the Claremore Clinic, and we put out the media portion of it and got with one of the local tech schools that offered it, I think that'd be a big help to the clinic.
Yeah, it would. There was I'm thinking maybe back 10 years ago where the dental assistant market was saturated and the dental assistant programs were dropped. And now we're back where we are now, where we need the dental assistant. Thank you for mentioning that, Darrell. Any other comments? The next meeting is scheduled for Monday, September 12th at 12:30. I need one more motion. Second. All those in favor? Aye. Any opposed? Meeting adjourned.